I just made a last-minute change to my presentation, and instead of telecardiology, I changed it to e-cardiology. And the reason behind that is that the way forward is that we don't separate things into silos, but we talk about information technology and cardiology as one single space that can improve outcome. My key message here, and that's my second motivation for changing the title, is the fact that you are a very powerful group here. You have the power to set the standards for interoperability, and you have the power to change the IT practice of cardiology. And I will support this premise in my talk today by talking to you about a little bit about what's going on at the European level, talk to you about semantic interoperability, e-health, standards, and the critical thing, which is called testing. And then I will go on into the practical side and share with you some of my experience, good and bad ones. Some of them I share with Alberto here, OpenECG, like 10 years' work, which could amount to nothing or something, depending on what we think and how we see things, how we view things. And then my more recent work with implantable cardiac devices, which is called e-CARDIO. And then I will go back to my key message, which was you have the power and you can change the state of play with interoperability, with the use of information technology in cardiology. And I hope to do that in 15 minutes. Guess what? So the first thing is the digital agenda. And this is a slide from Neil Cross, which talks about sustainability of the health system, the fact that we cannot sustain the costs anymore, and we do want to deliver better care with less costs, and we do want to stimulate the market so that new things come and care is better. And one of the elements, or one of the pillars here, is standards and interoperability, as you see. And the political goal is that we want to increase the number of healthy life years by 2. But this is not new stuff. You have seen this picture probably in one of my presentation or other presentation. It comes from 1924. It's the radio doctor, which allow us to do telecardiology or any tele-discipline. But we do want that to be sustainable, and we do want to do that to be integrated to the other functions that we have within cardiology. So the question is, what does interoperability have to do with this? And what does it have to do with cardiology? And I will move on to the human factor, the perception of cardiology. And this slide comes from Finland. And actually it comes from the doctors. And it is a questionnaire that was thrown out to the doctors, to the medical society, from their association. And they asked them, what does it mean to you? And as you can see here, it talks about the doctor who doesn't get the data that he wants. It talks about the doctor that he cannot get the imaging. It talks about the doctor that cannot get the patient summary. It talks about unnecessary investigators. And again, the one that I am very much associated with is the right side. And maybe some of you are as well. No? It talks about the patient who loses his prescription. Imagine in a strange place, you need your medicine and you forgot your prescription home. So that's what interoperability is about. And that's what the key, I guess, activity at the European level is about. But specifically for cardiology, there is a new initiative at the European level. The ESC is somehow involved on the side of that, and it's called Semantic HealthNet. It's a network of excellence. It's a virtual network, many organizations, many experts. And the topic is semantic interoperability in cardiovascular medicine, heart failure, and prevention. And I like very much the slide here, and this comes from Deepak Karla, which actually captures not only the primary production of data, but also the different kinds of secondary use of data. And you can see also the issue of privacy, the issue of anonymization, the issue of consent. So let me spend like half a minute here to explain, and I will speak loudly enough to be understood. So data is produced at the community level, and that's important data we don't capture yet. Social care, occupational health, school health, fitness, all this is relevant to cardiology. Then there are the points of care, the continuity of care between the departments of the single institution, and then long-term continuity of care across regional, national borders. And you have now teaching and clinical trials here where you have to have explicit consent, and you have educational clinical cases where you do have to have both consent and the identification of data. And I guess most of you have some experience with such isolated cases. On the other side, we have disease registries. This is a hot topic right now in Europe. Cancer registry, cardiovascular registries, all different kinds of registries that capture what's going on out there, the base for evidence-based medicine. And then there is public health. And all that, the vision is to come in real time back to clinical care. So with this big challenge in their hands, this project, which started just last December, took the different parts, trying to fit them into the puzzle. And you see, one aspect is privacy, the other one is the data records that exist out there, the other one is terminology systems, the other one is workflow. So the vision is to make sense of all this, and that's what semantic interoperability is about. And it is, I think, fortunate that the topic that has been chosen for this is from cardiology, signifying how important cardiology is and how difficult the problem is. And I will give you some more data about the difficulty of the problem. They have 4 years to find a reasonable solution and a sustainable solution via virtual organization. So I will go step back a bit to make the message a little bit more piecemeal. So I'm an information technologist, and I've worried about this question. Many of you may have also worried. What is a good electronic health record for cardiologists? And this comes from the US. It's from a congressional budget office. So they said that to persuade the politician to give money for interoperability, and they say they can reduce tests, they can reduce medical errors, administrative costs, reminders, decision support, and comparative effectiveness and risk information. There is actually a standard there. But not many people know about that. And the reason that not many people know about that is the fact that there are 2 different worlds. This is an ISO HL7 standard which talks about the models of electronic health record. And it's actually a 2-level standard. In the first level, you have functions like direct care, supportive functions, information technology, security, and so on. And in the second level, you have different kinds of profiles for different disciplines, cardiology being one. So let me take you now to the next step, the role of societies. And the American College of Cardiology released a wonderful document for cardiologists that are practicing. And the topic was, what do you do when you go out to either influence the decision about the purchase of an EHR system or buying an EHR system for your own practice? So here are 8 questions. The first one is, does the EHR allow you to meet your goals for adopting an electronic health record? The second one has to do with certification criteria, and I will get back to that. The fourth one is about cost. The fifth one is about interoperability. Can you access data from different sources? Then there is the technological infrastructure, security support, privacy, and so on. And then whether you have support in updating this record, the ASP model, and then what your friends are doing. Do you know? Have you go shopping around, reviewing other solutions? And then how easy is it to change if your needs change? I promised to go back to the difficulty of the problem, and this is an excellent work that I would suggest that you go ahead and review yourselves, and it has to do with the certification criteria for cardiology, for electronic health records in cardiology. And you can see here how, if you look at the data, it's a big Excel sheet of, 20 points, which says, all the different things that you need to integrate together to form an electronic health record in cardiology. Going back to standards, I have to rush, I'm going behind. There are different standards that are involved here, and there are also profile organizations that are making the implementation guides that will make the standards fit a particular workflow, the workflow of a specific department. There is HL7, big, all over the place. Many different working groups, sometimes criticized about the width of the different issues that it addresses. The most successful and relevant to cardiology, I think, is the structured documents work, which finds a lot of room within IEHC, so it models the clinical documents that are exchanged in a healthcare organization. And then there is the IEHC, lots of leverage. Still, there is some debate whether it has been put into play, into daily practice. It is selecting standards, customizing them into use cases, and then tests them into connectathons, and then finally, vendors can publish integration statements. There are two different IHC domains that are very relevant to cardiology. The one is patient care coordination, which reflects the profiles, and it has different patient summaries for different situations built on the clinical document architecture. And then there is patient care devices, which is where a lot of activity is happening because of the multimedia nature of the data in cardiology. I would like to pull your attention to this graph here, which is the basic outline of what's happening in these profiles. You have somebody that is a device that is creating an observation. This is the reporter. You may have some filters, and then you have the consumer of the information, which could be an electronic health record system, which could be a secondary use that identifies whatever you can think of. IoT is important in the device world, particularly in the personal health devices, and then there is a profile organization that deals with that, and that's Continua, which is certifying devices that they can be plug and play, and there are also device design characteristics that are published. But the thing that I feel that we need to support more as a community is testing. IAT has done leaps and bounds within the EPSOS project, which is for cross-border prescription, building the Gazelle architecture and system, which takes test scenarios, has test data, and tests the integration of different systems with real systems and actors. Very important work, but we need more. So the HITS project created this roadmap, which says how to map the different levels from the local, the international, and the project level. Again, this is work in progress. We need to go into certification. How much time do I have now? Okay, so having rushed through this, I have talked to you about the challenge of semantic interoperability. I have alluded also about standards and some basic profiles and profile organizations, and then I will try to share with you my humble experience trying to take this work and put it into practice. So it all started in 2002, and that's the time that I met Alberto and a gang of 5 or 6 or 7 people that were very influential, and I feel so privileged to have worked with them. So the idea was very simple. I mean, we were doing a big network in primary care, and the only thing that I have very strong ideas and convictions sometimes, and I'm criticized about that, but I wanted a very simple thing. I wanted, no matter which ECG recording device I had, to be able to put the data inside the primary healthcare record, so that it is really multimedia, so that I have the waveforms no matter what device recorded. So at the time, in my naivety, I tried to persuade people, and I managed. I'm surprised that I did, because they were, I guess, more experienced than I was, to start up this project. We got funding, and it is amazing how much people bought on this idea. People from different organizations, different backgrounds. And that's what OpenECG was born. We had funding from 2002 to 2004. We continued, myself and more than myself, I have to give credit to Franco Chiarugi, who had more expertise being with the industry so many years. We did support manufacturers for 10 years. As I said, 2 years with funding and the 8 years on our free time. The network, the internet network grew. We have more than 1,000 people in this network from 69 countries, 2010 data. But we are tired. I mean, it has to be sustained in a better way. And the question is, what's the best way to achieve sustainability? And I'm looking to you as a possible group to take up the effort and keep up the effort, because it's a long journey. But I think there may be light at the end of the tunnel, judging from the Heart Rhythm Society, that they are now demonstrating IHC work there this May in Boston. So that's one thing. That's the past. For now, we are working on implants. And thank you very much, Ino, for setting the stage for this. You are persuaded by now that telecardiology could work. The question is, how does it work in the integrated space of information that I tried to paint for you? There are different devices. These slides are credit to Joseph Burgada. It started in Europe, 2000. It got market approval, and there can be remote telemonitoring. It actually works. We saw and speak about that. There is actually an expert consensus from the EAC and the ACC, and it's up to be updated. That's what I hear. So we have guidelines on how to do this. There are lots of clinical trials. I will slightly change the message of Ino here, because we are not sure that we save money, but we are sure that less complications arise with implantation after we have telemonitoring, and we may have more visits in the beginning, in the first 3 months. So our challenge here was to integrate information going back. So we have data in the electronic health record, we have data in the personal health record, and we have data from the device. The question is, can we use guidelines to improve care, to save visits, save going to the hospital? And we built this architecture. It seems complicated, and it is, because this part is the manufacturer. And I have this video by Ted I will share with you, which says people are asking for their data, but there is a lot of tension with the industry here. They don't see a business plan in sharing the data. And then there is the challenge of the hospital, and there is the challenge of compliance, the person, and there is the doctor that wants to make his work better. We are working here with St. Jude and Medtronic to merge the data from the two. And we work in a specific hospital. I have to acknowledge Salzburg Hospital in Austria. We built the system. It's based on IHC profiles. And, well, I have to conclude. I'm running over time, and I have to apologize on that. My message is what I said in the beginning. We need the standards. But we need a home for the standards, a home that has the ability to make the change happen. And I'm looking at you with a sense of hope that you may be able to change the game. Thank you very much.
Catherine, thank you very much for your extensive and very clear overview of the situation. Are there questions from the audience for Catherine? Okay, Alberto.
Thank you.
Caterina, you cited the time of OpenHEG. It's on. Of the OpenHEG project. At that time, the problem was the selection of the best format of the data. And at that time, the winner was the SCP-ACG protocol. My question is, now, at the distance of 10 years or more, which is the situation? Is still the SCP-ACG is the best format for the ACG integration, or there is something different?
I guess now with the maturity of 10 years, I think the issue is a different one. The issue is, do we go for the data, for the waveform data, or do we go for PDF or paper, for an image? So is it waveform or image? And at the time, if we talked about waveform, there was DICOM there, which came from the electrophysiology lab, and there was SCP-ACG, which was a much more flexible format. It still is, but very difficult to implement. So I don't think it's a question of format. It's a question of information. Give me the information in a single unified format. I had a short discussion with one of you yesterday, and he said, we don't have the resources to implement standards. Well, that's the reason. There are too many of them. If we could agree on one plug, then we wouldn't go around the world carrying all those adapters. But again, the issue is the data, is the information. And in the waveform, you have much more information than you have in the paper. And I must say that thanks to Paul Sluter and his intense work with the Rosetta project, and also his dedication to getting the waveforms out, we may have waveforms in IHE next year for implants, for instance. But it's 10 years. Thank you. Nick?
A question related to that question. If the standards is not an affordable goal because you don't have the sources, you don't have the needs, is it not time to reach the second goal, that is to develop a converter box in which you convert every format to another format?
There is some, okay, this is an interesting question, and I have a story to that, which I'm not sure. Anyway, is it affordable? What are the economics? What is the business plan? There is a story from the implantable world there. There was a company, I will not name the name of it, which developed such a package from ICDs. And it was bought by one of the big players. You know what was the next step? Each one of the players in the market changed the format so that that particular device, object, box, was worthless. Well, you could argue that they changed because the needs changed, the protocols, so-called changed. So it's a continuous effort. There is a piece of box that could happen, but it requires the commitment of the community, of the industry, and it requires a push from the people. It requires the push from the consumer. And I think that's our only hope. But to happen, I think it needs people like us, people that are engineers and cardiologists.
Catherine, I have one additional question on the same lines. The last slide, the project with the implantable devices and exchange of data, you've shown that there are, I think, 3 fields that are important there. The companies, the hospital has to implement the standards, and the cardiologists who have to say that they need that. Where do you think the biggest problem is?
There are different problems that come from different sources. Each one of these boxes has its own problems. So I will thank you very much for the question. This box here, each company has to release its own data. You have to map the data from different companies. We had a paper in EMBC last year where we mapped data from St. Jude and Medtronic. So this is one thing. And I talked about the story of the box. So this is one thing. There is a push, and there is a wonderful TED video that I hope that we can distribute with the presentation, that you can see where people are asking for their data, like they do for their blood pressure. But this is one problem. Probably that can be solved with a different push. The second one is the hospital and the medical device directive. Now, in many countries with the update of the medical device directive, any kind of software that is used to provide decision support is subject to the medical device directive. So if you want to extend this, you run into problems if you break through the barriers of a single hospital. And the house of the consumer is one extra place that is not within the trust domain of the hospital. So there is a policy issue there, which is huge. And then this one, I think, is the best one. I think we didn't get a lot of problem there, probably because we had a very active group of cardiologists supporting them. They took the guidelines of the ESC, they turned them into protocols of care, and I think they used them to improve the way that remote monitoring of ISTs worked. So,
okay, thank you very
thank
much
you
for the
for the question. Yeah.